Welcome to Boards with Purpose. It's great to be having a chat with Martin Laverty, CEO at Aruma, and Virginia Bourke, Chair at Mercy Health. They've got some fantastic insights on the care economy and how we're making sure that our loved ones are looked after properly, how they're thriving in care, whether that be aged or disability care, and that fantastic difference that good governance can make for the care economy. In fact, I was thinking in the lead up to today, you guys have got one of the most important jobs in Australia, looking after those people in care, whether that be our mums, our grandmums in aged care, our kids in disability. It's a really important area that you're involved with, and I'm mindful that brings a lot of pressures with it as well. So let's kick off in terms of care governance. Where do you see care governance sitting? How has it evolved? Martin, I'm going to kick off with you.
Well, just so that we all know what we're talking about, first Phil and Virginia, I see care governance as the spectrum from hospitals through aged care, through childcare, disability care, and it's perhaps important. That's the experience that I've had across those four segments of the care economy. And common to all of them is a path to professionalisation. That yes, hospitals have been around for hundreds of years, but they've been required in recent decades to professionalise. We've only had care standards for our hospitals for the last 3 decades. We've had them in aged care effectively for 2 decades. Childcare, they've been there for 2 decades, but they've really been reformed in recent times. And in disability care, that is the very example of what was once families, community, that is now being professionalised. And as taxpayers who are funding all of these systems, and for those of us that have our family, our loved ones in care or working in care, we're all quite focused on how do we keep people safe? At the same time, how as a nation do we afford it? And for the director that's overseeing either the hospital through to the disability care service, they're confronted with all of those pressures, those expectations all at once. And a key theme that I want to unpack a bit today is that in disability, in childcare, where the governance standards are still evolving, we've got a lot to learn from hospital care that's worked it out a few years beforehand. And that's why I'm delighted that Virginia's here, because she's had that direct experience in hospital and aged care that can help inform where childcare and disability care is going.
Absolutely. And it's keeping them safe, but it's also thriving, right? So it's not just about,
Yeah, that's right. You can really see the development of clinical governance over, well, I'm thinking over the last 30 years, where healthcare institutions had various crises and so forth, and clinical governance, care governance became, a field of expertise and development. But Phil, to take up your point, now in the new Aged Care Act, we actually have a definition of high quality care. And it doesn't mean just keeping people safe. It means allowing them to live in a way that respects their dignity, that allows them to engage in behaviours that might actually cause them harm. Indeed, that's called the dignity of risk. We allow people to undertake activities that they want to undertake. So there's, I think, this huge development also in understanding what is quality care, what is the care that we're trying to deliver to the people in our services. And I think also there's been a growing understanding, certainly within aged care, that we really need systems that are integrated across our organisations. So when we talk about clinical governance or care governance, that is an integrated framework that tells us what is the standard for our organisation in terms of delivering care. And it will include roles and responsibilities and the policies and processes that we need, and it will give us all a common standard to aspire to, but is not just sitting in a silo. And I think directors need to understand that, and that has been an area in which there's been a lot of development in director understanding, and continues to be, I think, a need for the director community to understand what does care governance mean now in a contemporary setting, and how can we really deliver care that enables people to live full lives? And that is so often, I think, completely aligned with the mission and the vision, particularly of our organisations, which are in the not-for-profit sector. Many are also faith-based organisations. And I think all of us have this common commitment to providing care that recognises the dignity of every person.
Phil, can I just tease out Virginia's very astute observation? Having worked alongside boards of hospitals, of aged care services, currently disability, but also being involved in childcare, I've seen generalist directors, ASX directors, really, really talented people with extraordinary skill sets come into these environments, really good on overseeing financial risk, quite in the dark about how you consider care outcomes, whether it be the well-being and welfare of children in childcare, or how you see and know in disability care that good is happening. These areas are still ill-defined. And right now we're asking a lot of a generalist director to come into an area where clinical governance is at a different level in maturity. Yes. In hospitals, clinical governance is clearly established. Systems exist. There is professional training for clinicians. In childcare, what is the outcome of a child's day in a centre? What is the outcome that you measure for a disability support hour? These are still maturing and evolving areas of clinical governance that we don't have black and white answers for. So for those directors coming in, having that contextual understanding, but also really importantly, how we quickly get to common definitions of what is the standard of care, what is the outcome that we're after. But in disability and childcare, I still think there is a maturing that aged care and hospital care is a little further advanced in.
And we've also got a lot of directors who have probably been around these organisations for years and may not have picked up on the world has changed. And I see that as a real issue as well, of actually getting people to understand that the world has changed and the expectations on them as directors are different than they were a decade ago.
Yeah, that's right, Phil. There's been a huge shift in community expectation of our organisations, I think, and so therefore in terms of director accountability. And that played out through the Royal Commissions, aged care, disability, mental health in Victoria. And so I think that means that directors now have to have really a far more developed understanding of the organisations that they are governing. It means that you really have to bring a disposition, which is quite different, I think, to the disposition directors might have had 20 years ago. You have to take a very proactive and diligent approach to understanding your organisation, understanding how care is delivered. Now, that is a really significant shift. And I think also, certainly in aged care, that shift, which has been going on for a long time in a general sense, I would say, but now coupled with the Royal Commissions and legislative reform, particularly the new Aged Care Act, there's now a direct accountability for the health and safety of the people in your care. And there are civil penalties, I should say, that are extensive and that are now linked to the delivery of care. So I think most directors now, I think, are understanding that there has been a huge shift and it affects the way that you practice as a director. And I think that's what we're talking about today is really how do you practice as a director in this changed environment? There is increased penalties and accountability for you as a director. But more than that, the whole shift has been towards the human at the centre of care. And that's a really big shift. And we've seen it in legislation when really the old Aged Care Act really was about providers and financial sustainability and so on, or financial accountability. But now the shift is the human, the person delivering care, the older person in the case of the Aged Care Act is at the centre of the Act. And that is the focus for the director. And I think that shift has probably been mirrored in your sector as well. Martin. I'd be interested actually to see whether you feel the same shift.
Well, this gets to the nub of the challenge. How do you know when the person-centred, the human-centred care outcome is being delivered? In an episode, in a surgery, in a hospital admission through an ED, you're able to track what was the healthcare outcome of that episode. In aged care, not only now is there a regulatory obligation, but you can see through the absence of harms, through engagement, through wellbeing. In disability care and childcare, we don't yet have that universal measure, but we do have regulator expectation. And in recent times, the number of occasions I've heard directors say, how would this look if I had to appear before a Royal Commission and explain a decision of my board, of my executive, around some of those outcomes? I think directors, the benefit of there being a string of Royal Commissions that are often criticised for not achieving much, the benefit is it's changed the attitude of executives and directors to think, if I was on the stand, how would I explain this, even if the system, even if the definition of what a good outcome in childcare or disability care is ambiguous to me? So I think directors have a benefit by that type of scrutiny. It's changed mindset, and that's in the interest of us all.
So in the Royal Commissions, all of them, I think we've seen examples where, to be honest, directors were asleep at the wheel. They didn't fully fulfil their duties and obligations that we would now expect to occur. And of course, as a society, we do learn from those examples. How do we get the learnings of those Royal Commissions more broadly understood? How do we get that director community? And do we need to be sourcing a different cohort of directors to make that happen?
Well, I think the most profound Royal Commission that we've had in recent years was the inquiry into sexual abuse of children within institutional settings. It's had a profound impact on the way in which we safeguard children and young people, of expecting voluntary organisations that did not have formalised or mature systems of governance, and it's cascaded across all parts of the care economy, not just because parts of the care economy are still not-for-profit, volunteer-led in many cases, but it's illustrated what happens when you leave governance in abeyance for so long. I think there's been a profound impact of the Banking Royal Commission on the not-for-profit care economy as well, that directors that live in the worlds of finance, that live in the worlds of markets, are seeing that even those institutions with extraordinary or seemingly really well-established systems of both governance and accountability within them were left wanting because of the decision or the lack of activity of directors. And to hear within the boardrooms in which I work those references, it indicates that the Royal Commissions have had a positive impact. They've actually alerted directors to that idea of someone always looking over their shoulder, not just the shareholder or the members or the mission purpose, but the idea of regulators requiring reasonableness in how decisions are made. And to hear directors in board meetings, particularly when there are options and ambiguity, how would this look? Would I be seen as reasonably fulfilling my obligations in relation to a care outcome where that care outcome's definition is ambiguous? We're better off for that, but I'd also say let's not have any Royal Commissions for a while, because to some extent the sector's been Royal Commissioned out. There's only so much you can eke out of these sectors before you have to get on and just build your systems of governance.
So we've heard, I think, lots of organisations now moving into having various structures, practice governance frameworks and the like. And Virginia, I'm sure Mercy Health has had those for quite a while. But I'm imagining for smaller organisations, these can be quite challenging things to have set up. What are you seeing in terms of orgs dealing with that?
Well, I think that certainly the Mercy Health is a large organisation, and yes, we've had clinical governance frameworks for 30 years, but it is always an iterative process, and the focus is, including under the Aged Care Act itself, continuous improvement. So this is a dynamic process, and I think no matter what your size or scale, you need to be always thinking, what is the best practice here? What is it that we can do better? And so I'd say that every organisation now needs a clinical governance framework. So it's an integrated framework that will tell you what are the systems I need, what are the roles and responsibilities for each layer, for the point of care, the volunteer, the manager, the executive, and what's the role of the board here. And I think that's helpful no matter what the size of your organisation. But I think, Phil, your question probably goes to how do you resource that expertise in a sector where everyone wants the same expertise? So I think that's a real challenge. There are a lot of resources available now. So I think even smaller organisations can probably access a range of resources. The Commission certainly is indicating that it has a disposition to assist organisations that are struggling, as does the department itself. So I think there are ways to approach the challenge of whether you have a clinical governance framework in place. But I think one of the dangers is not to simply rely on the clinical person on your board. Now, within aged care, we're now required to have a person with clinical skill and expertise on our boards. We cannot simply rely on that person. It is both unfair and also that is not the point of the reforms. So I think that all directors, no matter what the size and scale of your organisation, we all need to upskill in clinical governance. It's a bit like I'm thinking back to the Centro case.
When we just had the one accountant on the board.
And out of that, I think most directors will recall that now you simply have to be financially literate if you are a director on whatever board that you're on. So I think similarly, out of all of the royal commissions and the reform, the legislative and regulatory changes, you must be literate in care governance, in clinical governance to serve on boards. And I think that's the responsibility of directors. And people can complain about that and say it's all too much, but it's not actually, because it's the point of our organisations. So I think that it's appropriate for us to expect a high standard of engagement of the director community on this. I think the resources are there, but I do appreciate and have spoken to some directors who are finding that a struggle, or they may be finding it difficult to attract directors because now to the list of things that you must be across is care governance. And some people are actually a little bit fearful about care governance, clinical governance. They say, I'm not an expert. But that's not the point of being a director. You have to know enough. You have to know enough about your organisation and about the risks and issues in your organisation to ask for the right information in the boardroom so that you can ask the right questions. And that's the practice I think that directors need to have. Ask the right questions. But to do that, you need the right information. To have the right information, you need to know enough about your organisation.
And you need to have the right people, right? And I'm thinking as our society in terms of providing great care across all of those care sectors, we've got a lot of organisations requiring directors, requiring executives. Have we got the cohort of people that can actually take those roles on? Is that going to drive change in the marketplace?
Well, Phil, it's easy enough to attain financial literacy skills to be a director if you don't have them. The ability to read a set of accounts, to understand balance sheet movements, yes, it obviously matures over time, but it's a generic skill. And there's lots of support, AICD in particular, about developing that. Clinical governance, the oversight of a human care outcome, is a bit more tricky. So yes, our doctors, our nurses, our allied health, or those that have been around the healthcare sector, they've got a real good head start. But in this world of overseeing really large human service enterprises, where births occur and deaths are part of the daily routine, establishing those skills is confronting for some. It is unfamiliar, and I don't think we've got a really good path to provide us with a pool of directors that we're going to need, particularly in those areas that are themselves still professionalising, which is disability. Our hospital governance around the country, we have to say, is not too bad. Our aged care governance around the country is still maturing, particularly to your point of smaller NFPs that might be regionally or rurally located. I think there's rapid variability in the oversight of childcare, and disability has got a long way to come. But part of that is we have to establish clinical governance at board in exactly the same way that we have financial governance at board. The two need to be given equal positioning, because you need to have a viable organisation that fulfills its financial obligations in order to exist. But your licence to provide a service in the care economy means that you have to have functional governance over whatever part of the human services you're providing. And we're not there yet. And it troubles me because I see it playing out in organisations, particularly under the NDIS. An extraordinary time of uncertainty, of reform, of rapid change, where directors have really got to have their wits about them. They're struggling with the financial pressures of the NDIS right now, and some are doing really well with the clinical governance oversight, and others, I think, need real help. It's in fact an area where not just the AICD should step in, but I think there's a role for the regulator in disability to acknowledge that we're still maturing the system of disability governance and it needs some support.
And it's a different market as well, right? You've got a very long tail of very small organisations or still family-run businesses, probably both in early childhood and disability. A swathe of that middle tier and then some very large providers. I'd always expected to see more in terms of merger activity happening in that space. Probably.
I think it will drive merger activity, the pressure of regulatory change, of clinical governance requirements. I think that is a real factor.
There are less hospitals in Australia today than there were 30 years ago. There are less aged care providers in Australia than there were 20 years ago. It will be the same. As population demand and service demand has increased, there's been consolidation in hospitals, in aged care. You can see some consolidation in childcare, in disability care. Good Start Learning is the perfect example of where really clever NFP leaders stepped in because of a commercial sector governance failure in childcare. And you've got to say, Good Start Learning today is the standout provider because they've worked out their quality governance. They're really specific on their purpose. They know on what good outcomes and how to facilitate them because they've got a system of quasi-clinical governance overseeing it. The smaller childcare provider, and similarly the smaller not-for-profit disability provider, doesn't have those same opportunities to embed those practices, even that state of mind. While you're struggling to just sustain financially an NDIS organisation at the moment, the opportunity to really spend time on and invest in your quality governance is constrained.
Yeah. I'm mindful of the processes, but I'm also very mindful of the need for the right culture to be going on within the organisation to meet those expectations. How are you doing that in a big organisation?
Well, I think the monitoring of culture is actually part of the clinical governance framework should be part of the clinical governance framework that you set up. So the way in which you monitor culture in an organisation, again, an area which has been under some development for some time, that's an important part of clinical governance, as is the level of engagement with consumers, with the patients, residents, clients. So both of those things are actually part of a clinical governance framework. And I think one of the traps is that clinical governance has been perceived perhaps in a narrow sense, when really it is a much broader and system-oriented aspect of governance. So those things are really important. And without, when you think about this, the really significant clinical governance failures, and an example would be the Oakden aged care facility in South Australia, which really was the precursor to the push for a Royal Commission into aged care. When you think about one of the defining factors in the many horrendous failures there was a toxic workplace culture in which no one could speak up, in which indifference to the clients, the residents, was the norm within that workplace. So that, that's the worst example you could have probably. But it was the culture of that place, the culture of the oversight, which was really no inquiries were made. There really was very limited oversight. But all of those aspects were found to be factors in care failures. So I think, Phil, that is absolutely critical to your clinical governance framework. And in turn, the clinical governance framework, one that is embedded, will drive your organisational culture. It will be the focus. So I think they're just critical aspects of the framework itself. But I just wanted to comment on, we were talking about the director, the pressures on directors. There's also this sort of inherent tension, which I think is quite difficult for directors in the care sector, that, well, perhaps I'm thinking really mostly of aged care here, that we have a requirement now under the Act that we deliver high quality care, that's now defined, and that our organisation is adaptable and that we can continuously improve. There's a dynamism within our organisation. We'll adapt to technology, to AI, we'll improve outcomes for our clients. So this is required of us now, and it is proper, and we'll have the human that we're looking after at the centre of our organisation. But at the same time, the director must also be mindful of a really increasing regulatory and compliance overlay. So you've got those two things which in a tension, or there's almost sort of a paradox there, a really significant focus on compliance and a requirement to be a continuously improving and agile and adaptable organisation. And I think often for directors, that tension is very difficult to balance. And you can overweight on compliance, and it's a huge tendency to do that because, you want to make sure that your organisation is run properly and so on. So I think sometimes naming that tension, not everyone wants to live in that tension as a director. And I think that's one of the challenges too for attracting people to our sector. It's going to be really hard to have a dynamic, forward-looking, engaged board when you're also almost weighed down by a significant regulatory compliance layer.
While you've still got to make a profit to be viable and invest in the future, at a time where the taxpayer contribution in particular, or the consumer contribution, is becoming increasingly constrained. This is not an easy environment for any of us to work in. We do so because it's centrally important and really rewarding. But I do think that time of the director volunteering in particular in the not-for-profit sector to serve on the local childcare, the local disability organisation, the local aged care, and even to some extent putting your hand up to work on the local health district board as well. The burden needs to be really, truly understood. Continuous improvement, regulatory interaction, constrained funding, and then the consumer expectation. That voice of the consumer, the consumer-driven care that has to be at the heart of this is sometimes not given the priority against those regulatory continuous improvement and financial arrangements. So not straightforward. But I think it might be important for us to give that assurance that even with this complexity, we are still seeing extraordinary outcomes across the care economy. And this idea of learning clinical governance, of ensuring that directors understand it, needs to be made accessible. Let's perhaps try and unpack what we mean by clinical governance. In my mind, it's that there is an evidence base, that you have an appropriately skilled staff working on that evidence base, that you have systems of monitoring and oversight, and that you have a consumer voice at the absolute centre. Now, that's a really simplified way of talking about what clinical governance is. But the director who sits atop of that system should see all of those things operating. And if they can't, they need to be asking the questions as to why not, and ensuring that you get on to a position where you know what the evidence is. There are guidelines to inform the type of staffing and the way in which they work, that you have the systems of monitoring and reporting up, transparency, if you like, not just because the regulator needs it, but most importantly, what is the consumer experience of the receipt of whatever human service they're receiving? If you've got those basics right, that's clinical governance in practice, different in hospitals as it is to childcare, but they're the types of principles. And if we see those in the same way that we know we have to prepare for financial audit, we have to be monitoring our monthly management accounts to make sure they are heading us in the right direction, we're budgeting, it's got to be seen as just as important. And in some of these environments today, there's still some work to do on making them equal.
And in terms of getting the board packs and the information that you receive, and they just keep getting bigger and bigger and bigger, right? How do you make sure that you can have that right messaging in there, that and from an executive perspective, that you're not bluffing or overloading directors with the information, but similarly, the directors need to be asking for the appropriate information. How are we going to get that balance right?
I think that is a constant, it's a work in progress. In every board that I have been on that is a work in progress is how do you get the level of director information right? And of course, when you have a really significant regulatory or legislative shift, you have to do that work all over again and make sure, are we meeting these new standards? What do they really mean? Have we got the evidence that we need? What's the data here? So at Mercy Health, we've spent a lot of time mapping all of the standards that are required across our whole organisation, both in health, in aged care, home care, residential aged care, and then really looking at what is it that the homes are monitoring, what's being monitored on the site, what's being monitored in the next layer up, which would be a clinical governance committee at a management level, and then what flows up to the board quality committee, and then what flows up to the board. And we've done a lot of work to make sure that at each of those levels, the appropriate things are being looked at so that the board really have an assurance function. That's what the board's role is. So it will be looking at various consolidated measures. It needs to understand what are the outliers in these measures, and then it needs to understand what is being done about the outliers. There's your continuous improvement piece. And the board needs to be satisfied that the insights that are flowing up to the board are being acted on and that the loop is being closed somewhere. Because I think a real trap, for care organisations is that, especially when you are financially constrained, which is, let's face it, much of the time, you can end up admiring problems as they come to the board month after month. Because there may be a reason that, financial constraint, workforce constraints, you might have high agency use for various reasons. Think back during the pandemic and in the time coming out of pandemic. So the board has to guard against complacency, that sort of being passive, I think. So that's why I think always the board should be interrogating not just the information that's there, but is that the information we really need to assure ourselves that the care that is being delivered, possibly 7 management layers below us, is actually high quality care and is actually meeting people's needs and is actually allowing them to flourish in their lives. So that is a work in progress for every board, and it is the work of the board. I think we've seen that in significant legal cases. The board must say that is not what I want to see. But to do that, you really have to understand your operation really well. And I think one of the key aspects for me in understanding the organisations I'm being part of are site visits for directors. And I think this is absolutely critical now. In fact, it can't be understated, I think, the importance of site visits. You get to observe and see a model of care in action, whether it's in a health service, aged care, residential aged care. You might be going along to a home care visit. So you get to see how your staff interact, you get a feel for the culture of various different sites. And it also just helps you understand what the risks are, and helps you understand how hard the work is at times. And I think site visits is something now that I think most directors have come to understand are absolutely critical. You need a site visit program, and you need to have objectives. You can't just, you can't just say to management, organise the site visits. The board needs to take responsibility for what is it that we want to get out of this. Do we want to have lunch with residents? Do we want to experience the dining experience as a resident would? Some of my colleagues I know in other organisations would say, I always stay the night in a facility just to see what is it really like here. So I think that's been a real shift that I've seen in 15 years of board work. I think that site visits are now absolutely integral to understanding clinical governance.
Phil, let me tell you why a chief executive wants site visits to occur. Because inevitably in human services, part of your clinical governance is facing up to the events that are adverse and the things that do go wrong. The context for how these events occurs is so important. And if you've not been into a disability home, a childcare centre or an aged care centre, you don't have that appreciation. You haven't had the chat with a disability support worker who perhaps used to be a butcher or a hairdresser and they've made that career shift. And thank goodness that they have. And it explains the context of some of that workforce. I've got on my board some extremes, and I'll name check some of my directors without naming them. But one tells me that the board of Walmart expects business proposals to be written in a single page. $100 million decision has to be concise enough to be in a single page. Another director, bringing the experience out of the financial sector, that needs several hundred pages of financial analysis to get to a decision. I think that word assurance that you've used, Virginia, the board needs to assure themselves through the information they receive, through them turning up in services, but really importantly, having that direct connection with the consumer, whatever form that takes. We have our consumer representative board attend every second board meeting, unfiltered, unagendered, talk about whatever you like. Directors on my board visit services before every meeting. It's part of the KPI. And it shapes the expectation of how to read a board paper or a proposition, particularly the more challenging ones when we're dealing with how to remedy adverse events or making decisions about financial viability that are going to impact people. But if you return to those central tenets as to what is good clinical governance, as a director, do you see the evidence? Do you have guides as to how services are to be delivered? Do you have monitoring and reporting for when things go wrong? And is the consumer voice part of that? If all of that is on display, you are seeing as a director the right types of information to satisfy yourself, providing that there is a strong complaints and reporting system for those adverse events, not just to the regulator, but those regular phone calls between chief executive and chair, or that reporting up to the board through the risk tolerances in your risk framework to say these events have occurred, here's how we deal with them, here's how we rectify them. If that's on show, you're in good shape.
I wanted to pick up on another word that Virginia used, the interrogating. And I'm sure you didn't mean it in this perspective, Virginia, but interrogation of the executive team. I've seen a bit of friction happen between executive teams and boards over recent time of an almost don't you trust us anymore kind of nature, as boards have had to delve further perhaps into the operations than they may have previously. As a chief executive, you obviously dealing with that on an ongoing basis. What do you get the sense of the right level of interrogation of you as a chief executive, Martin?
Well, I've been a chief executive for 20 years and simultaneously a board director for that length of time. And I've changed my view. I was once quite affronted when a board director would challenge something that I'd said, and now I run towards it and expect it. Because I understand, and I think good executives, experienced executives in particular, understand the different roles, The role of the director is to interrogate. It's the right word. There's a set of duties that I understand a director has and a set of duties that as an officer of the company, a chief executive has. I think if you're new to it, get used to it because it's the job. And it's not personal. It's about fulfilling the best interests of the corporation or the enterprise. And actually, the director who interrogates a chief executive is doing the chief executive a favour because they are aiding management in making the best possible decisions. My management team and I do regularly think, how is the director, individual director and directors collectively going to play out in this particular situation? A former colleague of both of us, I don't mind naming Michael Stanford, told me once, when he is writing a board paper, he writes his paper with all of the directors who are going to read it in mind, and he checks out the interest of so-and-so is X, the interest of someone else is Y. Have I addressed that when I'm preparing my paper? And I don't mind that little tip that Michael Stanford gave to me 20 years ago. I still carry with me today, and it means that I don't feel interrogated. And any chief executive who is defensive, the board should be digging further. Why is there the need to be defensive? Management and board are ultimately on the same team, working for the same objective, and the strength of the different roles is their contribution to the best interests of the enterprise.
And that governance as a team game is just critical, right?
Yeah, I think that's right. I've been thinking about really the shift in terms of community expectations, scrutiny on organisations, and all of the things we've discussed really today. All of that, I think, has meant that the board CEO, board executive relationship really has to be even more one of partnership, I think, than would traditionally be
Big time.
Conceptualised. So I think the best executive teams, the best CEOs welcome respectful challenge because they like to be tested on their ideas, on their thinking. So I found that the challenge or the interrogation of the board is entirely of the executive is entirely appropriate, and really the effectiveness depends on the sense of mutual trust between the board and the executive CEO. That is even more important, I think, in a care organisation, and the high degree of trust that is required, that is the key ingredient. If you trust each other, then you can challenge each other respectfully and effectively. And I think that really in the climate that we're in, that sense of working together has to be really quite evident to everyone, to both the board and to the executive.
We're getting close to time, but I did want to touch on measurement before we finish today, because at the end of the day, we've got to know that we're making a difference to people's lives, right? And yet my observation is many organisations are struggling to probably measure the right things, and some of them are intangible. Who wants to have a crack at measurement?
Activity is really easy. You can count, but outcomes very different. The experience, I think, that we can learn from hospitals. Hospitals have outcome measures about the efficacy of their care services. You know if a hospital admission has been successful. You know if a surgical episode has been successful. Today, we don't have those same measures for disability care in particular. And I think in childcare and aged care, we have different expectations about what an outcome might be. Beyond, we kept people safe, fed, and their welfare was in check. We'd expect, now that we have child educators in childcare, to have really concrete measures about meeting learning milestones. In disability care, we've got that opportunity to define what those measures of success are. I don't like just being measured on my safety outcomes, and that's as mature as our regulatory standards are. So some of us in the disability sector are actively designing what are the outcomes around person-centred care? What are the outcomes for supported decision-making? How do we ensure that the consumer voice, where the consumer's voice is challenged because of their disability, that we ensure we are delivering the services that they choose in the way they choose. So it's not yet clear. There's not a universal agreement that gives us an answer. But I think if we look to the hospital sector that has needed to work it out years before, we should be expecting over time the same across aged care, childcare and disability care. Different outcomes, obviously, but that same outcomes framework that is not just counting activity.
Mm.
Yeah, I think that's right. I think there's an increasing maturity in aged care in surveys like resident or client surveys of, and also, Net Promoter Scores, that's becoming more common. I think there's still some way to go in terms of patient outcomes in the hospital
Fair
system.
Call.
So
Yeah, fair call.
I think that this is an area where we could all do a lot more work. And often, of course, what the patient's idea of an excellent outcome may be different from the surgeon's and all of that, as you would know, Martin. But I do think that it's an area where we are getting better at asking residents, are you happy? Are you lonely? Do you have social connections? Because these are the real test. This is why, families look to us and trust us, is that their parents or their family member or their loved ones will be happy in our care, that they will feel safe, that they will have social connection. So I do think that there are many improvements in towards surveying and understanding residents, but that a long way to go, I think, for our sector.
And it'll be fascinating in a decade's time, right, to look back and see where some of these subsectors have gotten to in terms of their ability to measure and report on the outcomes they've achieved. It's been great chatting today. It's such a fascinating area of our society. Yes, it is the care economy, but it's bigger than that. As I said in the intro, it's about looking after our loved ones. And thank you for doing the roles that you do. And thanks for having a wonderful chat today. Cheers.
Thank you, Phil.
Most welcome.